Level 5.
Sorry, did you say go ahead? Okay, I'm gonna get started now. Can everybody hear me? Just if somebody could let me know in the chat.
We can hear you, Curtin.
Okay, thank you. All right, I think everyone knows me right now. I'm Kevin, one of the first year fellows. I'm going to be talking about toxicological emergencies and ingestion of toxins. I have no relevant financial disclosures. I just wanted to give acknowledgements before, just in case I run out of time. So thank you to Dr. Flom. Thank you to Dr. Evangelista. He's one of the hyperbaric oxygen therapy doctors, and he helped me out. Also the clinical pharmacist and our lab techs, just because it'll come up in my presentation. So these are some of the very common toxicities that are seen in the ER and also the ICU. Patients who have aspirin and acetaminophen toxicities are most common. Antidepressants and antipsychotics, opiates, of course, recreational drugs also, and some of alcohol and their alcoholic derivatives, and carbon monoxide and cyanide poisoning. And I'm going to be touching upon the majority of these, if time allows. Just before I get started, I just want everyone to kind of know, I think everyone kind of knows this already, but the Poison Control Michigan phone number, they're very helpful, and especially when they are admitted to the ICU, they kind of give us updates, or they call for updates. And then we have 2 staff toxicologists here that I found their numbers on, actually in our fellows room. Their numbers are listed, so I'm not just giving out the phone number. It's actually provided for us as Dr. Malone and Dr. B. So the various alcohol toxins. This next slide is pretty busy, so we'll just kind of go one by one. The first toxin of alcohol, we see a lot of these patients who come in for alcohol intoxication and then develop alcohol withdrawal. Sort of symptoms, signs and symptoms we already kind of know. They're pretty altered. They have slurred speech, unsteady gait, just being drunk. Um, Pertinent labs, patients usually have a high anion gap metabolic acidosis, mostly from ketosis, and high osmolar gap too. They can also have either a high alcohol level or zero, and that's usually when they're about to go into withdrawal. Um, I have a typo there. Usually you'll have high urine ketones and high lactic levels also. The mainstay of treatment for alcohol poisoning or alcoholic toxin poisoning is supportive care, administering IV thiamine, electrolyte withdrawal, electrolyte replacement, and monitoring for withdrawal. Um, Obviously, if these patients go into renal failure or any other liver toxicity, that's a whole other topic. But for just alcohol toxin poisoning, that's the treatment. More serious toxin poisoning is methanol and ethylene glycol. So for methanol poisoning, usually you see these patients have altered mental status. They will have some sort of retinal toxicity. They usually come in with blurry vision, central scotoma, afferent pupillary defect, and can even have photophobia. Um, Usually patients that have methanol poisoning are um, they're from like painters or patients who for some reason ingest um, windshield wiper fluid. That also goes for ethylene glycol too. There are some very severe complications of methanol poisoning, even if they are treated appropriately. They can develop severe necrotizing pancreatitis. They can have permanent vision damage or loss. They can develop transverse myelitis and even kidney failure. So the most pertinent labs in methanol poisoning is, well, one, the methanol level, two, the high anion gap metabolic acidosis, and these patients also have a high osmolar gap present also, um, and they also have a lactic acidosis. The mainstay of treatment for these patients are administering fomepizole if they uh, meet the indications for it. Fomepizole reduces the action of the alcohol dehydrogenase by inhibition. Methanol becomes formaldehyde um, by ADH and then oxidized into formic acid, which is the primary toxin. So administering fomepizole uh, inhibits alcohol dehydrogenase, so you prevent the formation of the primary toxin. Usually you give them a 15 milligrams per kg loading dose, and then followed by 10 milligrams per kg every 12 hours for 4 doses after. It's also important to give them sodium bicarbonate, um, especially because usually these patients do have pretty severe acidemia. Um, Giving IV folic acid, 50 milligrams Q6. This is it's a theoretical benefit to increase their elimination. There's really haven't been any studies or anything to show that it does improve it, but um, you can give it, and they actually do recommend it. And then, of course, dialysis if it's indicated. So these are the indications for fomepizole administration in patients who have methanol or ethylene glycol poisoning. So if their initial level is greater than 20, if they have a history of ingesting methanol on their osmolar gap is greater than 10, um, or if you don't have an actual um, methanol or ethylene glycol level, but you have a strong clinical suspicion based on where they were found or their medical history, then you can administer fomepizole if they have two of the following. So pH of less than 0.3, bicarb of less than 20, or an osmolar gap of more than 10. Um, and then these are the indications for hemodialysis. So if their initial methanol or ethylene glycol level is more than 50, if their pH is less than 7.25, if they are in just fluid renal failure, or if their clinical picture picture is worsening despite supportive care. And you also see that in patients who are renal failure, they're becoming have refractory hyperkalemia. Then you would, of course, then do dialysis anyways. So just kind of going back to this chart, ethylene glycol has a little bit different uh, clinical manifestations. So usually these people, patients have nephrotoxicity. So they have renal failure, renal dysfunction when they present. They have hematuria, they might have flank pain or oliguria. They could also have come in with seizures, tetany, or even cranial nerve palsy. And they also can develop QTC prolongation, which usually is not seen initially, but that is something that can develop. Just like methanol poisoning, these patients have high osmolar gap with a high anion gap metabolic acidosis. They also can have calcium oxalate crystals in the urine. Calcium oxalate crystals in the urine. That's pretty specific for the ethylene glycol. They usually also have extremely high lactate levels, and that's one sort of way that you can sort of differentiate with methanol, although there's not too many other ways other than their clinical presentation. Hypokalemia, and then of course, looking at their ethylene glycol levels. Treatment is very similar, as I already mentioned, using fomepizole, sodium bicarb. They also recommend IV thiamine in addition to IV vitamin B6. Once again, these have not been studied or shown to have really any benefit, but it is recommended. And then hemodialysis, which we've already covered. And the last toxin that we're going to talk about, or alcoholic toxin, is isopropyl alcohol. These patients usually come in pretty altered. There's like CNS depression. They're kind of like in a stupor or coma. They have a dysconjugate gaze, absent ciliary reflex. The only sort of differentiation that you will see, and this is very specific on boards, or at least the medicine boards, was that they have a high osmolar gap, but they do not have an anion gap metabolic acidosis. And then other things that you help diagnose this is their acetone levels and isopropyl levels, and serum and urine ketones. The isopropyl and acetone levels are not very common in every laboratory. And they mentioned that it's not, the treatment is very largely supportive. So if you can't get the actual level, it's not that big a deal. But our lab does do acetone and isopropyl levels. And if you type in volatile screen, it actually is like a 5-part screen for methanol, ethylene glycol, isopropyl, ethanol, and acetone levels. And according to the lab, it is a 4-hour turnaround. It's a send-out lab, but it comes back within 4 hours. And I confirmed this with the laboratory techs. All right. I think we have any questions on that so far. Okay. I actually had Kahoot questions, but since we've moved to virtual, somebody can just type their answer in if they want. So a 40-year-old gentleman with no prior medical history is brought by his wife for acute onset severe nausea, vomiting, headache, and lethargy. He was painting the house and dropped the entire can of paint stripper and spent a couple hours cleaning it without a mask. Since then, he's had worsening headaches and vomiting. He has no falls. He had no falls while painting. His vital signs show a blood pressure of 140 over 80. He's tachycardic in the 120s. Normal-ish respiratory rate. He's afebrile, and he's 98% on room air. His examination is mostly unremarkable. He does have some small areas of bluish discoloration, but that's about it. He's alert and oriented times 1 to 2, very sleepy and drowsy on examination. No focal neurodeficits could be seen. While you wait for a CT head, what would be the next best step in management? So A, would you get an EKG? B, would you get an ABG? C, a urine drug screen, or a neuro consult? Anyone? Please, not all at once. No? All right, well, the answer, oh, somebody answered. I don't know about the chat. Right, so Chris and Crystal said ABG or B, which is correct. And that leads me to my next topic of carbon monoxide poisoning, which is one of the leading causes of poisoning deaths in the United States. Unintentional carbon monoxide poisoning has a 1 to 3% mortality rate, and intentional carbon monoxide poisoning can have a mortality up to 40%, mainly because of the delayed um, delayed treatment. Mainly can be found in patients who are involved in house fires, have old or poorly functioning heaters, live in very poorly ventilated areas with vehicles. Some of the things that they talked about is our people who work at ice rinks, very poorly ventilated, and then they have the um, machine that helps clean the ice rinks. They do have an increased risk of carbon monoxide poisoning. And of course, paint stripping or paint thinners due to the active metabolite methylene chloride. This is just like med school 101 here. Carbon monoxide poisoning causes um, is rapidly absorbed in the lungs and has a higher affinity for oxygen to heme, nearly 250 million times more than oxygen. So it kind of kicks out the oxygen and binds to the heme, and that causes you to have an abnormally or falsely elevated oxygen on your pulse ox, but not actually, your PaO2 is usually lower. And then on the left here, you see your oxygen hemoglobin dissociation curve, and you have a rightward shift because you have a higher affinity for oxygen and a lower oxygen delivery or loading. So elimination of the carbon monoxide depends on the degree of oxygenation and your minute ventilation. So half-life of carbon monoxide on room air is about 250 to 320 minutes. If a patient is placed on a non-rebreather or high flow, your carbon monoxide half-life reduces to 90 minutes. And if they're placed in hyperbaric oxygen, it reduces to about 35 minutes. So what are some things that we should be looking for in patients who have or have suspected carbon monoxide poisoning? So they usually have very non-specific symptoms of headache, altered mental status, dizziness, ataxia. They could also have seizures. And a common feature is tachycardia. Nearly 42% of patients that come in with carbon monoxide or confirmed carbon monoxide poisoning have some degree of tachycardia. I bring up the cherry red skin because we've all kind of learned that was always in like USMLE and UWorld, but only about 2 to 3% of patients that come in with carbon monoxide poisoning actually have the classic cherry red skin. So it's a very poor um, examination finding, but yet we were always taught about it. And then patients also have reported to have myocardial injury. Um, So this was an article, a prospective cohort study that was in JAMA in 2006, which looked at patients who had carbon monoxide poisoning and followed them for about 7 years after, and looked at what the effect of carbon monoxide had on their heart. And it was found that about 37% of patients who did have carbon monoxide poisoning did have myocardial injury. And that was seen based on their EKG and elevated troponin levels. And they followed them about 7 years after that, and a median follow-up of 7.6 years. There were about 54 deaths. About 24% of those patients died. 5% of those patients actually died in the hospital during that admission because of anoxic brain injury or any other burn injury, or a cardiac arrest. And then 85 of those patients who did sustain a myocardial injury from carbon monoxide poisoning, 38% of those eventually died because of other non-myocardial related problems. And this patient population that was studied was actually a mean age of like 42, I believe, and patients who did not have underlying cardiac history. So it just kind of shows that patients who do have carbon monoxide poisoning, number one, they should definitely have a cardiac workup when they come in, including a baseline EKG and troponin levels, but also they should be monitored once they leave the hospital. Somebody in the chat? No. So carbon monoxide poisoning, the diagnosis is made by carbon monoxide levels, but also based on your clinical suspicion, based on the HPI and your examination. And getting levels from your oxygen levels from your ABG versus a VBG is important because your pulse ox, as I mentioned before, will show like kind of like 100% in room air when they are not actually 100%. There are some institutes that have carbon monoxide oximetry devices, which can help determine the actual oxygen versus carbon monoxide levels, but they're not readily available in most places. So they recommend getting ABG versus VBG. Or these are two I guess studies that were done comparing ABGs versus VBGs. The bottom one is a prospective study that was done, published in the Annals of Emergency Medicine, comparing carbon monoxide levels in arterial versus venous gases. A very small study, had 61 adults, and the correlation between these two showed an R-squared value of 0.98. Mean difference between the two levels, between the arterial and venous, was 0.15%. And the top was actually study was submitted into the Journal of Critical Care Medicine. Was the prospective study also, which compared arterial carbon monoxide and venous carbon monoxide, and also carbon monoxide levels from a central line, from the IJ line. But this was done in piglets, not humans. And they tested blood from each of these various, so arterial, venous, and IJ, every 30 minutes for 6 hours. And the correlation R-square value is about 0.94. So they actually, a lot of the literature that I looked at did say that you can get a VBG, although I think most places do at least try to get a baseline ABG. So the treatment for carbon monoxide poisoning is oxygen. They recommend high flow oxygen because, as I mentioned before, it reduces your half-life to about 90 minutes, which is still pretty long. So I forgot to mention the normal values in carbon monoxide poisoning. So normal values in non-smokers may be up to 3%. So just you and I, way up to 3%, but anything more than that is consistent with carbon monoxide poisoning. Chronic smokers may have normal values up to 10%. So anything above 10%, you should be thinking of carbon monoxide poisoning if they do have, or they fit the clinical picture. So we talked about oxygen and sort of the treatment for carbon monoxide poisoning, but what about HBO? And I don't mean HBO max, I'm talking about hyperbaric oxygen therapy. So there are some neurological benefits that occur with hyperbaric oxygen therapy, especially if it's initiated within 6 hours after exposure. But there's uncertain data, sort of conflicting data about sort of the outcomes and the treatment because of the heterogeneity of the carbon monoxide poisoning, the severity of it, the timing of the initial oxygen therapy, the duration of therapy, the therapy dose, and what people consider a neurological recovery. So that is varied quite a bit. The mechanism of action for hyperbaric oxygen therapy, it reverses the hypoxia by reversing the binding of the carbon monoxide to the cytochromes. It also reduces a widespread inflammatory process that occurs by reducing the myeloperoxidase activity, which is why you see a neurological benefit. Criteria, and this is from, I spoke to Dr. Evangelista about this. So usually within 6 hours of poisoning has the best outcomes, but they do offer it to patients who come in within 24 hours. Anything more than 24 hours, the hyperbaric oxygen therapy is not offered. Usually you need about one session, but that is also controversial. Some clinicians do multiple sessions, and this usually does reduce your half-life of carbon monoxide to about 30 minutes. Most common adverse effects of the therapy are anxiety and claustrophobia, and it's mainly because you're kind of in this chamber, but that can sometimes limit how long a patient can stay in there just because they're so anxious. They can have middle ear barotrauma, and also have reversible progressive myopia. And that's usually with multiple or prolonged exposure, mainly patients who are there for chronic wounds, but it can occur in patients who are being treated for carbon monoxide therapy. This was like a landmark article in the New England Journal of Medicine in 2002. It was a double-blind randomized control trial, which looked at hyperbaric oxygen for acute carbon monoxide poisoning. And patients were randomly assigned to 2 different groups. So either they got 3 chamber sessions with hyperbaric oxygen therapy, or they got 2 hyperbaric oxygen therapies plus a normobaric oxygen therapy. This was all done within 24 hours of them presenting for carbon monoxide poisoning. And what they found was that the cognitive defects were at 6 weeks and 12 months were less frequent with the group that got 3 hyperbaric oxygen therapies at about 25% versus 46% in the other group that got 2 hyperbaric and 1 normobaric oxygen therapy. And this was done in 2002. There's been multiple other studies after that, which I'll just briefly touch base on. So the top article was published in Chest, and essentially they showed patients who received hyperbaric oxygen therapy had a lower mortality rate than patients who did not. But mainly this looked at patients who were younger than 20 years old. And then the bottom article, it was published in the American Journal of Emergency Medicine in 2020. And it was a large observational study. And it actually showed no mortality benefit, but patients who did receive hyperbaric oxygen therapy had significantly lower proportions of a depressed mental status and were able to perform more of their ADLs at discharge. All right, I'm going to move on to the indications for hyperbaric oxygen therapy. So children who have carbon monoxide poisoning are usually kind of get that therapy regardless. Loss of consciousness, persistent altered mental status despite oxygen therapy, if they're pregnant, if their baseline or initial carboxyhemoglobin levels are greater than 25%, if they had prolonged exposure for more than 24 hours, especially for patients who are found in like a underground garage or something, or if they have evidence of myocardial injury. And we can't not talk about cyanide poisoning because it occur very similarly to carbon monoxide poisoning, especially if the source of the poisoning is a house fire. So house fires also create cyanide, leading to a dual poisoning. Patients who have profound lactic acidosis, usually greater than 10, and a pH of less than 7.2 should also be treated right off the bat for cyanide poisoning also. The treatment for cyanide poisoning is actually a dual combination of hydroxycobalamin. Usually you give 5 grams as an IV bolus, and you can consider 10 grams if the patient has a cardiac arrest or has any evidence of cardiac injury. Usually you have to monitor your LFTs because they can cause some transaminitis, and also creatinine as it can cause an AKI. Very common to have red colored urine post administration for a couple of days. That's not blood, it's just an adverse effect. And then also using sodium thiosulfate, 25%, usually a max dose of 12.5 gram bolus is used. And they recommend doing both. In our pharmacy, we have both. We have the Cyanide Antidote kit, which is just a hydroxycobalamin, but you can order sodium thiosulfate 25% separately. And I found this out here. When we give nitroprusside to patients, there is a risk of cyanide toxicity, but our pharmacy automatically adds sodium thiosulfate to the medication, so your risk of that is next to zero. All right, moving on from some of the gases to some pill toxicities. So acetaminophen toxicity, most common cause of acute liver failure in USA, Canada, and the United Kingdom. It's the second most common cause of liver transplant, and it causes nearly 60,000 hospitalizations annually in the United States and causes nearly 500 deaths a year. Intentional, of course, if a patient is having suicidal ideations or a suicidal attempt, but unintentional causes are patients who take multiple forms of acetaminophen. So if they're taking acetaminophen by pills, and then they also are on Norco, and they also take NyQuil, and you'd be surprised how much patients are not aware of what's in those medications, and they sort of just double or triple dose themselves. So the highest risk of developing acetaminophen toxicity is in patients who ingest more than 7.5 to 10 grams in an 8-hour period, or about 12 grams in a 24-hour period. Also, patients who have chronic liver disease are at higher risk, even with a smaller amount. Use of acetaminophen with other hepatotoxic drugs, especially drugs that can upregulate cytochrome P450, so things like rifampicin or isoniazid, if they're chronically have malnutrition, and also if they're greater than the age of 40. So this is just sort of highlighting the breakdown of acetaminophen. Usually you have acetaminophen breakdown into glucuronide conjugates and sulfate conjugates. That's if you take at an appropriate dose. If you take it at an excessive dose, then it's metabolized by the cytochrome P450 into a reactive metabolite called NAPQI. It's a very long name, but I'm not going to even attempt to say it. But that's basically a toxic metabolite. And when that accumulates, you have a depletion in your glutathione, which normally will render that to be non-toxic. But because you have an abundance of it, because you took an excess amount of acetaminophen, you have a buildup of this toxic metabolite, which then further causes hepatotoxicity, hepatocellular necrosis, and even oxidative injury. And it takes about 24 to 48 hours to see the hepatotoxicity. And there's usually about 4 phases that is associated with acetaminophen toxicity. So phase 1 is within the first 24 hours of the ingestion of the abundance of acetaminophen. So non-specific symptoms, abdominal pain, nausea, vomiting. They could be a little lethargic, but very non-specific. And you wouldn't really know this unless they actually told you that they took a lot of Tylenol, or sorry, acetaminophen. Phase 2 is between 24 and 72 hours after ingestion. You'll start seeing some lab abnormalities. Usually they'll have elevating LFTs, they have a prolonged PT or INR. They could even have evidence of hepatomegaly on just their examination or on imaging, and have worsening right upper quadrant pain. Phase 3 is 72 to 96 hours after ingestion. LFTs usually peak at this point. It could be usually in the thousands. Their mental status worsens. They're visibly jaundiced, and their nausea vomiting is pretty profound at this point. And they could also develop concomitant renal failure. Phase 4 is 96 hours and 2 days after ingestion. So they could either have improvement and to be on the road to recovery, or they could progress to multi-organ failure and even death. So diagnosis is made based on your acetaminophen level, your serial LFTs or chemistry panels, serial INR levels, and also looking at the Rumack-Matthew nomogram. So this is a nomogram that's used for determining potential toxicities based on serum acetaminophen levels and hours after ingestion. The solid line is the treatment line, and the dotted line above is actually the Rumack-Matthew line. And the reason why the treatment line is a little bit lower is that because it allows for a margin of error. But essentially, it looks at if you're above the dotted line, you have about a 60% risk of hepatotoxicity if not treated, and a 5% death. So if a patient comes in at 4 hours post taking an entire bottle of acetaminophen and their level is about 150, based on the treatment line, you should definitely treat it, but you have a 60% risk of hepatotoxicity if not treated. So it's good for prognosis and sort of risk stratifying. This nomogram is not valid for patients who come in after 24 hours of ingestion or overdose, if you don't know what time the ingestion was done, or if they have a history of repeated super therapeutic ingestion. So if they took more pills multiple times throughout the day, then you can't really use this nomogram. So management, as we all know, its mainstay is NAC. We can also consider GI decontamination with activated charcoal, usually 1 gram per kilogram up to 50 grams, unless there's contraindications, which are usually if there's a risk of aspiration because they're altered, they have bowel obstruction, or if they ingested the acetaminophen with other corrosive material. So NAC therapy or acetylcysteine, most effective if given within 8 hours of ingestion. The risk of hepatotoxicity then decreases to less than 5% if administered within 8 hours of acute overdose. Excuse me. It prevents the hepatic injury by restoring the hepatic glutathione, which I mentioned before. It renders the NAPQI non-toxic. Also has a role in protection against the reactive oxygen species, and it actually has shown to improve hemodynamic stability and prevention of cerebral edema. And this is just that same picture again, showing acetylcysteine and how it restores glutathione, so it prevents the buildup of the NAPQI toxic metabolite. So as I mentioned, NAC is most effective if given within 8 hours, and that's because of this article that was done in 1979, I believe, in the BMJ. They looked at patients with very high risk of developing hepatotoxicity, usually patients who took like large amounts of acetaminophen. And it showed that if patients were given treatment with N-acetylcysteine within 8 hours, 0% of those patients had liver damage or any kind of hepatotoxicities, versus patients who got N-acetylcysteine after 15 hours, 82% of those patients developed liver damage. So that's where those numbers come from. And this study also showed that patients who received N-acetylcysteine within 10 hours did not develop renal failure either. So we talked about the nomogram already, but if you can't use that nomogram because the time of ingestion is unknown, then based on their acetaminophen levels greater than 10, or if they have elevated LFTs, you give them NAC therapy. If they've had multiple ingestions throughout the day and their level is greater than 10, or they have elevated LFTs, you can give them NAC therapies. If their acetaminophen level is not readily available, like if you work in a hospital that's like a send-out lab or something, then you treat it as if they ingested a dose of more than 12 grams. Okay. So the NAC dosing therapy is based on a standard 21-hour protocol or simplified 20-hour protocol. We do the standard 21-hour protocol here. So you give a 150 milligram per kg loading dose, which is given over a 1 hour, then 50 mg per kg over 4 hours, and then 100 milligrams per kilogram over 16 hours. There is a new simplified 20-hour protocol, which some countries in like Europe are using. This eliminates the third bag, I guess, but it also has shown a decrease in adverse effects that can occur with NAC, and mainly those are nausea, vomiting, rashes, and as severe as anaphylaxis. And they do 50, you essentially get the same dose. You give 200 milligrams per kilogram over 4 hours, and then 100 milligrams per kilogram over 16 hours. But you just eliminate that extra bag, and I guess it's 1 hour or less. But there have been a couple of cohort studies done to show that it does reduce the risk of adverse effects, including anaphylaxis, in using the simplified 20-hour protocol. The first study that I looked at was done in Australia. It looked at 476 patients who received NAC therapy because of acetaminophen toxicity. About 5% of those patients got reactions, including anaphylaxis, versus 14% who did not, who got the standard therapy, which is a relative reduction of 66%. The second study that looked at it was also a Denmark study, also found to have a significant reduction in their adverse effects. This did not look at which study is better, which protocol is better for hepatotoxicity. It was mainly just looking at the adverse effects from NAC therapy. And there's also a newer 12-hour protocol, which gives a loading dose of 50 milligrams per kilogram per hour for 2 hours, and then 20 milligrams per kilogram per hour for 10 hours. And then you stop the infusion if all these three criteria are met. So if your INR is less than 1.3, your ALT is less than 100, and your serum acetaminophen level is less than 20. And these were the two studies that looked at the 12-hour protocol. So the top one is a randomized controlled trial, and it looked at 21-hour protocol versus 12-hour protocol. And the 12-hour protocol did show a significant reduction in adverse effects, but the study was not powered to assess how effective a 12-hour protocol is in against hepatotoxicity, which is why in 2019, this observational study in The Lancet was published, which looked at patients who received the 21-hour protocol versus what they call the SNAP 12-hour protocol of NAP. And there was actually no difference between liver injuries or the liver synthetic function between the two regimens. I already mentioned that our tier 1 policy is to do the standard 20-hour protocol after the 1-hour loading dose. And actually, I talked to one of the clinical pharmacists, and if they come from an outside facility for like a hepatology consult or for acetaminophen toxicity, we actually switch them to a 28 or 21-hour protocol if they're on a different protocol. And then there's a lot of discussion whether we should be doing IV versus PO. Obviously, using oral NAC is cheaper, but it has apparently a very horrible smell and taste. It smells like rotten eggs. So a lot of patients do not tolerate this. They have very severe nausea and vomiting. And the protocol is a little bit longer. It's usually 24 hours. And you can stop the oral NAC if the level is less than 10. If their ALT or AST are trending down less than 1,000 or not elevated at all. And if unfortunately they do develop liver failure despite NAC treatment, the only treatment modality that improves their survival is a transplant. And we use the King's College Hospital criteria to sort of determine if they should be listed for a transplant. And in order to be listed for a transplant or at least be considered for it, they have to have either their admission arterial pH has to be less than 7.3. That's just one criteria you need to be listed or even be considered for a transplant. Or they need to have grade 3 or grade 4 hepatic encephalopathy plus coagulopathy showing a PT more than 100 and kidney failure with a creatinine more than 3.4. The last two sort of markers here, the lactic and phosphate, they're not actually included in the criteria, but they do indicate a worsening prognosis if they don't receive a transplant. 10 minutes. So is there a role for dialysis in patients who have severe toxicity from acetaminophen? And there is. And the extracorporeal treatments and poisoning work group recommend intermittent hemodialysis if their acetaminophen levels are more than 1,000, even if NAC is not administered. If they have evidence of altered mental status, lactic acidosis, and severe metabolic acidosis with an acetaminophen level of 700, and even if NAC is not given, or if they have evidence of altered mental status, lactic acidosis, severe metabolic acidosis with a persistent acetaminophen level of 900 after NAC therapy. I'm just gonna quickly talk about the other common cause of poisonings seen in the ER and ICU, salicylate toxicities. So just to recap, aspirin or salicylate irreversibly inhibits cyclooxygenase 1, which results in a decreased production of prostaglandins, prostacyclins, and thromboxane. It also stimulates your chemoreceptor trigger zones, which causes nausea, vomiting, especially if it's used in excess. Also activates your medulla's respiratory center, which causes hyperventilation. It also interferes in your Krebs cycle, which then leads you to have anaerobic metabolism. So if taken appropriately, salicylate usually is absorbed in the stomach, and peak concentrations are reached within an hour, and the half-life is usually 2 to 4 hours. But if it's taken in excess amounts, absorption is then altered in the stomach, and your peak levels are not usually reached until 6 hours, and your half-life increases to about 30 hours. So some very common clinical manifestations are nausea, vomiting, abdominal pain. Classically known that causes tinnitus. They could have altered mental status. They initially have a respiratory alkalosis because it triggers hyperventilation, but eventually will cause a metabolic acidosis. And although it's pretty rare, but some of these patients do develop ARDS. They could have if not treated appropriately, you could have liver and renal failure, thrombocytopenia, and also arrhythmias. This is just a sort of a great illustration I found on EM Docs that sort of shows the toxicities. We've kind of already highlighted majority of it. So the medullary stimulation causing hyperventilation, and then eventually increased renal bicarb excretion to cause metabolic acidosis. But you also have metabolism in the fatty acids, which then cause ketosis, and then a high anion gap metabolic acidosis. And it also causes the anaerobic metabolism, which causes lactic acidosis. So salicylate toxicity diagnostic testing. So usually your serum salicylate has to be more than 40. Anywhere from 10 to 30 is sort of normal, and fatal levels are more than 10 grams. Fatal levels if a patient takes more than 10 grams. They often have lactic acidosis. They have a bump in their creatinine, or just come in with fluoride renal failure, especially if they have chronic kidney disease. Patients sometimes have hypokalemia. And the reason I stress that is because hypokalemia needs to be treated aggressively in order to treat salicylate toxicity as you're trying to do urinary alkalization. Once you have hypokalemia, you're having absorption of your potassium and secretion of your hydrogen ions from the hydrogen potassium pump in the distal convoluted tubule. And that sort of prevents you from having urinary alkalization. And hyperchloremia also it's actually a false elevation. Some labs can't identify salicylate versus salicylate ions for chloride, so you have a false elevation in your chloride. So management, looking at airway. So when patients come in with hyperventilation, that's actually their way of protecting the cells from the toxicity. I'm doing a presentation. Hyperventilation is their protection. And if they need to be intubated for, whatever reason, because they're not protecting their airway, or if they're, they need for having respiratory failure, that comes with a lot of risks, because you drop your minute ventilation, and that causes acidemia at that point. They also recommend IV fluids, but as I mentioned, a lot of these patients do have pulmonary edema, and about 7% of these patients go into ARDS. So just be cautious of that. If they come in acutely after the ingestion, you can give them activated charcoal, which is 1 gram per kg up to 50 grams within 22 hours of ingestion. And it can be beneficial, especially patients who took extended release tablets. And then I mentioned already keeping their potassium more than 4 to help with the treatment. But the mainstay of therapy is the alkalization of the urine with bicarb. Bicarb pushes and giving them a sodium bicarb infusion to titrate their urine pH to 7.5 to 8, and checking their urine analysis every 2 hours. Usually if you're doing this, their patient's already in the ICU. Respiratory alkalosis is not a contraindication to be giving bicarb, and you want to titrate how much bicarb you're giving to an arterial pH of 7.5 to 7.55, and you want to prevent anything more than 7.6. So you'll also be getting Q2 ABGs or VBGs. So you want to keep them pretty basic. So. And then you also want to do Q2-hour salicylate testing, and you stop all this treatment once their level reaches less than 40. But some patients do have refractory salicylate toxicities and do not respond to urine alkalization. So dialysis is recommended for patients who have either initial levels more than 100, or if 90, patients with CKD, or if they don't respond and their salicylate levels are still greater than 90 after you treated them with bicarb. If they're in acute renal failure with a creatinine more than 2, if their GFR is less than 45, if they're coming in and they're already looking like they have pulmonary edema and you're not able to give them bicarb, if they have worsening mental status or clinical decompensation. 12:57. Don't think I have enough time to do everything, so I'm just going to go to some of the cardiac meds that can be toxic. So beta blockers and calcium channel blockers are very common to have toxicity, mainly because they're so widely used for multiple reasons. Beta blockers can be used for obviously cardiac benefits, but also for anxiety. Calcium channel blockers are used in addition for headaches and cluster migraines, things like that. So beta blockers, obviously they'll have bradycardia, they'll have hypotension. A lot of patients present with hypoglycemia, hyperkalemia, and they usually are lethargic. A lot of these patients do have unintentional overdoses, and that's mainly because their dose has been increased or their dose is the same, but they're going into worsening renal failure from the baseline CKD, or if they miss dialysis and some of these medications are removed from dialysis. An intentional overdose most commonly occur with propranolol because it's used for patients who have general anxiety, and that can be, unfortunately, a suicidal attempt with propranolol. And propranolol has an added sodium channel blockage, so that can lead to a widening QRS, and so we should be looking out for ventricular arrhythmias also. Sodalol overdoses, they usually don't have immediate toxic effects. They usually have a delayed effect. And patients that have Sodalol overdoses or toxicity need to be monitored for QTc prolongation and things like torsades. So the therapy or management for beta blocker toxicity is obviously supportive care. We can consider GI contamination with activated charcoal, whole bowel irrigation, oral gastric lavage. Whole bowel irrigation is used especially for patients who have extended release beta blockers or calcium channel blockers. And activated charcoal, if they don't have the contraindications, can be used within, especially if they took it within 2 hours. But the main therapy is the glucagon, which has positive ionotropic and chronotropic effects mediated by adenyl cyclase that causes an increase in cyclical AMP and causes an influx of calcium. So usually you give them 3 milligram bolus, and then you can give an additional 5 milligram if they don't have a response, and then start an infusion at 5 milligrams an hour. The max dose is 10 milligrams an hour. If none of these modalities work, you can start vasopressors. And they recommend norepi or epi. And then for calcium channel blockers, and I'm talking about non-dihydropyridine calcium channel blockers, such as verapamil or diltiazem, because dihydropyridine calcium channel blockers, such as like amlodipine, don't really have much of an effect on the heart. But usually with this toxicity, you'll see bradycardia, hypotension, hyperglycemia is usually noted. Patients are usually not altered because calcium channel blockers have been shown to have a neuroprotective effects, but eventually they can cause seizures and can have altered mental status as time goes on. Treatment is very similar to beta blocker toxicity. You have a supportive care. You can do GI decontamination for the same indications I said before. Atropine is not effective, but you can try it. Treatment with IV crystalloids is important. They're usually pretty hypotensive. And treatment with IV calcium gluconate is important. So usually you give 2 to 3 grams initially, followed by repeating calcium gluconate up to 9 grams. If that doesn't work, then you usually have to put them on vasopressors. And you can consider a high dose insulin protocol. So it's hyperinsulinemia, euglycemia. The exact mechanism of action, how it helps is not exactly known, but it does, hyperinsulinemia improves ionotropy and peripheral vascular resistance, and reverses acidosis by possibly by improving uptake of the carbohydrates in the myocytes and smooth muscle cells. And this is just our an epic when you want to start this therapy. I just like search high dose insulin therapy and it comes up. And it's very physician driven, as opposed to for like DKA insulin drips or nurse driven. You give bolus of 1 unit per kg. Then you start them in a high dose infusion at 1 unit per kilogram per hour. And you increase this by 1 every 30 minutes up until you reach the max dose of 7 units per kilogram per hour. And you usually have an average therapy about 24 to 48 hours. You want to keep their glucose level anywhere from 120 to 200. So normally you have to start a D5 drip also. I don't think I have enough time for digoxin toxicity. I think Eric is next, so I'll just kind of end there. Does anybody have any questions or comments? Oh, chat. Yeah, for sure, Dr. Tatum. All right, well, thank you again. And then I think Eric is next. Thanks, Dr. Flom.